Thank you very much for the invitation. By way of introduction, I'm working as a clinician in Copenhagen, but is also director of the WHO Collaborative Center on HIV, Viral Hepatitis, and TB, and therefore is advising countries across the European region on how to handle these three infections. Thank you for the invite. I was going to be focusing on MDR, which in the area of the world I'm working is becoming a real concern, in particular among HIV patients. I'm no complex. As you know, there is overlap for the three conditions among high burden countries, TB, MDR TB, and therefore, and also HIV, and therefore, as a consequence, TB, HIV, and in particular, for these countries in the middle here, also MDR TB. If you look at the burden of new MDR TB cases across the world, it's of no surprise that the biggest caseload are in countries where the background TB incidence rate is fairly high. And they obviously spread here in Asia, in Africa, and in Latin America to some extent. But the focus that I've had is on the countries in the eastern part of Europe. This is a part of the world that remarkably still have a trend of new HIV infections compared to every other region or continent of the world, and this continues to increase. As a consequence, it's not unexpected that there's a 13% average annual growth of HIV prevalence among TB cases from 2006 to 2016. And these data are from the TB office at WHO Europe that kindly provided it to me after an update from data from Russia recently. There's been a pretty remarkable improvement in TB control in the region, overall in the population, with a 5% annual decline between 2012 and 2016. On the other hand, among HIV patients, TB has been on the upswing with a 9% increase annual over the same couple of years. Have the real conglomerate of this is, of course, that the TB that you see in HIV patients in the region have many of them MDR TB. It's estimated that 8 countries are reporting MDR prevalence over 20% among new pulmonary TB cases, and this is particularly seen in HIV patients where the prevalence of MDR TB can be as high as 70 to 90% on a clinic base. One of the challenges that the region is exposed to is that antiviral treatment rollout has been fairly slow, although improving over time, and as a consequence, AIDS-related death overall have continued to increase from 2000 to 2016. Antiviral treatment coverage has been improving, as you can see, between 2010 and 2016 in the region across all the countries, although it's still falling behind 27% in 2016 compared to the global average of 53. So although a lot of efforts has been made, there's still an enormous pool of HIV-infected people who is not on antiviral treatment, leaving them obviously susceptible for progression to active TB disease if they're exposed. We of course know, and we have shown that experimentally, even in early HIV disease, that if you put people on treatment, you reduce the risk of TB. You see that the improvement even in people with essentially a normal CD4 cell count. You see that benefit from putting people on treatment already within the first 3 to 4 months after treatment, and then it levels off, providing you on relative terms with a protective effect of around 70 to 80%. And this is, of course, true irrespective of whether the TB is fully drug susceptible or MDR or XDR, leaving a lot of people at benefit if further antiviral treatment coverage was improving in the region. In terms of people who's actually diagnosed with TB, how is the region faring? Again, there's been improvement in TB mortality overall, but it's been counteracted by increases in mortality rates over time among those who's presenting with TB and HIV combined. We have been having a lot of interest in this and have constructed several prospective studies in the region to further detail on the clinic level what are the issues and what are the barriers. I'll briefly go through those data. This was the first, was essentially a survey assessing sort of the model of care that Alison Grant was already alluding to, and you can see that on all fronts in Eastern Europe, the model of care is very decentralized, HIV and TB, compared to, for example, Western Europe, allowing for people to only access antiviral treatment once they have dealt with their TB care management in one institution and essentially have to transition from one place to another, which obviously is not very helpful. Also, if you looked at something as simple of drug susceptibility testing in the region compared to Western, Southern Europe, or we also included colleagues from Latin America as a comparison. You can see that the number of TB cases which was definitively diagnosed and where you had the drug susceptibility testing available was only around 30% in the region. That means that if you actually, since drug susceptibility testing is not expert, it's the original cultures where you get the data available after 1 to 2 months of treatment, you could essentially, even among those where drug susceptibility testing was available, you can essentially predict how active the TB drugs that they were placed on at the time of initiation of the TB drug, how effective there was. And yes, you can see it's around 1/3 of the patients in the region were started on drugs where there was either 2, 1, or no active TB drugs, which is true for HIV and for TB, is an excellent environment to propagate further resistance. The other issue in the region is, of course, that among the people who is identified with TB, only 61% are actually diagnosed with HIV at the time of diagnosis, and quite a few is offered antiviral treatment. So therefore, it's really of no surprise, as we published a couple of years ago, Daya Potlikareva and Dr. Efson quite nicely and convincingly, I think, showed that mortality in people in the region is very elevated compared to Latin America and to Western Europe. A short note on the shorter course MDR TB regimen, which have achieved high treatment success rates in selected MDR TB patients. If you assess the percentage eligible in different European regions, you can see it's single digits, which is in contrast to, for example, Brazil or Pakistan, where it's around 50% of people that could be subject and fulfill the requirements for the shorter course TB treatment. So this is essentially not an option that you're left with, and therefore, if you have documented MDR TB, it's the 2-year course. In terms of access to newer anti-TB drugs, bedaquiline is used in 89 countries, and most of them is actually in Russia and South Africa. Hopefully we can discuss this, although I have to say that some of the bedaquiline is used as functional monotherapy, rendering resistance to that drug as well, and belamidid is also being rolled out. So in this very short presentation, the summary on the convergence of MDR TB and HIV, there's a high MDR caseload in India, China, and Russia. Prevalence of MDR TB among TB cases is highest in Russia and neighboring countries, where there remains an epidemic transmission of HIV, a low ART coverage, leaving a large population of antiviral-naive, HIV-positive, immune-impaired patients, allowing fast transition from TB infections to active TB, which is why we see the much higher prevalence of MDR TB in the HIV-positive population in that region. Drug susceptibility testing is only made in 1/3 of the TB HIV cases, and if there is a drug susceptibility testing done, 1 in 3 starts with 2 or less active TB drugs, and less than 10% fulfill criteria for WHO recommended short term. So therefore, the focus areas that we keep pressing on is to scale up antiviral treatment coverage, strengthen all aspects of the HIV continuum of care, better coverage of drug susceptibility testing, including second-line TB drugs, assessment for them. New and novel second-line drugs is obviously important to continue to develop, and we really want to make sure we are protecting those second-generation and second-line drugs, so we don't give functional monotherapy, because that's not going to be helpful in a region with such a high MDR prevalence. And obviously, we need to have new strategies to practically prevent and treat MDR and XDR TB. So with those words, I just want to acknowledge colleagues at the WHO European Office, the European Centre of Disease Controls, as well as colleagues across the region who's working hard to prevent HIV and TB transmission and improve health in their setting, given the constraints that they are working under, as well as people back home in Copenhagen. Thank you very much.